Yeah.
It's helped them reflect and so what is it your website
Yeah.
They've done some really great work trying to support them on the back end.
I was just at Ferb, over so many times I've heard passions of fuel policy exchange. So, and they really
Another really exciting company.
Oh, good. Well, I hope you don't.
No, I'm sure.
Yeah, I mean, I've done some. What were you specifically? Well, okay. So you must be busy right now. No, I'm not. Yeah, me too. And I also had you for me. So on there, did you register to be a contractor for putting on
Hi everyone, we're starting now. Hello and welcome to the third annual SPPH Exchange 2019. Before we begin, I'd like to acknowledge that we're privileged to stand upon the unceded traditional territory of the Musqueam people.
My name is Sophie Kitchen, and I am your co-chair for the 2019 SPPH Exchange Committee, and I'm also a second-year Master of Science program at the School of Population and Public Health.
I'm Zina Yesufu, also a co-chair for the event and a first-year MPH student. Other members of the committee are Julie Zhang, Maria Jaramillo, and Chidubem Okechukwu, all first-year MPH students as well.
The SPPH Exchange is an annual student-organized conference designed to facilitate conversation about emerging public health themes and issues.
This year's conference is sponsored by the Center for Rural Health Research at the UBC Department of Family Practice, the Rural Health Services Research Network, and the Graduate Student Society. This is the third edition and is themed for rural health, a very diverse and salient aspect of public health, one that would benefit from more interest amongst young professionals, especially those in health and policy-related fields, just as we have here today.
We will begin with a keynote address, followed by an expert panel from members of the Center for Rural Health Research. And finally, we will have workshops with emerging leaders in rural health. And of course, there will be food and beverages provided. And then we will have a poster session and networking session.
Introducing the keynote speakers is Dr. Peter Berman, the newly appointed director of the School of Population and Public Health. Dr. Berman is a past professor of the Harvard T.H. Chan School of Public Health. Welcome, Mr. Berman.
Thank you very much. I was wondering if that's my cue. I have some nice notes that were prepared. So I'm very delighted to be here. It's great to be able to attend and open a student-conceived, student-organized event. For those of you who know at all about my arrival here, I've been, tomorrow is 2 months exactly. One of the things that I have not had enough opportunity to do is get to know our students. So that's very much on my mind, and you'll be seeing, I hope, and I intend that you'll be seeing much more of me. So I'm delighted to have this chance today, and I've already had a chance to sit in on a couple of classes, which has been really fun for me as well. I want to start out by telling you that your life as a student never ends. I spent this morning taking an English language test, which is required to apply for permanent residence in Canada. I don't know how I did yet, but I hope I passed. Otherwise, I don't know, I might have to go back across the border or something. It was tough. It was really tough. So I've been asked to say a couple of things about rural health research and rural health care. My whole career has been working on issues related to global health. I'm an economist, and I got started doing this right out of college when I had an opportunity to spend 4 years as a UN volunteer in Indonesia. And then I've had long experience living and working in Indonesia, another time going back to do rural health research for my PhD dissertation, looking at rural healthcare service delivery, both economic issues and equity and distributional issues, and then 2 also long stints working in India, mainly preoccupied with rural health care and rural health research. In the global health scene, we've really experienced a major transformation that I can see in my lifetime. When I started working in lower and middle income countries, in many of these countries, 70 or 80% of the population were living in rural areas. And rural health research basically was health research. I mean, that was where the people were, that was where the issues were, and that was the natural place to focus one's attention. Today the situation is a bit different, and in many of these same countries, half the population or more are now living in urban or peri-urban areas. So this has really been a big change. Rural health research is still very important, and there are sharp differentials between rural areas and urban areas, but not always the way we might assume that they might be. In other words, it's not always true that the people living in rural areas are necessarily have worse health conditions than some of the people living in urban areas. And the other interesting part of this situation that's been developing around the world, and I think this is true here in British Columbia, is that the concept of who's rural and who's urban has become much more fluid. People move. They move for employment. They move at different stages in their life. They might have part of their family in an urban area and part of their family in a rural area, and there's this exchange taking place, which also affects health and also influences what healthcare people use and what they do about their health problems. So I think it's very timely to have this conversation about rural health research. It's one of the key issues here in British Columbia as well, and especially when it is further confounded with or associated with significant disparities around Indigenous peoples and First Nations populations, as well as the fact that British Columbia faces some very particular problems of physical access and difficulty in communications and moving around, which affect the organization of healthcare. That's the part of the health system that I'm interested in, thinking about how healthcare services can be organized and delivered efficiently, effectively, with good quality in environments where resources may be very limited or difficult to put in place, or people may have difficulty accessing those services. So let me introduce our speakers. The Center for Rural Health Research and the Rural Health Services Research Network of British Columbia emerged in response to the need for an evidence-based reform to rural health services policy and planning in British Columbia. And our 2 speakers are experts in this area, and I know they have their own presentation planned for us, so let me just briefly introduce them both and then turn it over to them to organize themselves as they have planned. Dr. Stefan Grabowski is a professor in the Department of Family Practice at UBC and a family physician with many years of rural clinical experience. He's the Director of Research in the Department of Family Practice at UBC and held a Michael Smith Senior Scholar Award. He has a long-standing interest in rural health services research and building research capacity, both of which are exercised through his current positions as co-director of the Center for Rural Health Research and director of the Rural Health Services Research Network of British Columbia. Dr. Jude Cornelson is an associate professor in the same Department of Family Practice here at UBC, co-director of the Center for Rural Health Services, and an honorary professor at Sydney Medical School. Her professional life has been consumed with creating, examining, and sharing comprehensive evidence to support rural health planning, particularly in the area of rural maternity care. And I'm delighted to get a chance to listen to them because I'm going to follow up by sitting down sometime soon with both of them and learn more about what they've been doing. So please join me in welcoming Dr. Stefan Grabowski and Dr. Jude Cornelson, and I pass the floor over to you.
Thank you very much. Yeah, you're welcome. Thank you very much, Dr. Ferb. That was great. I really appreciate the nice comments you made about us. And thank you very much, SPPH and students, for inviting us to do this. I know we're paying for lunch, but that's our privilege. Just while I set up the slides here, we're going to start off with a video, I think. I'm just going to set the video up for 1 sec, so we'll just pause it. We've been working in this area now for, I feel like it's most of my life. I started off my clinical career on Haida Gwaii as a generalist physician, freshly minted, and I have to tell you I was a little nervous, more than a little nervous. Haida Gwaii is a long way from backup support, and so when you're in the front lines in a place like that of 3,000, catchment 3,000 people or so, you're it. And I was determined to catch babies, and then before I went up there, I went, I don't know if I really know how to respond to all the emergencies that can arise in maternity care, so I think I'll go to BC Women's and I'll sign up as a resident there for 6 months, and I'll really tune myself up. And so I did that, and it was probably the worst thing I could do, because I saw so many emergencies. I saw cesarean section done in a bed, I saw a whole bunch of things that I would probably never see in my practice life. But nevertheless, that's what I did. My mother was an obstetrician, so that was partly, I think, what was driving me in that direction. So we went, Jude and I started working together and created the Center for Rural Health Research in about 2004. And we've been working hard amassing evidence since that time. We've published about 50 papers now in the area of rural maternity services. And we put these papers out, and the papers were clear. The policy directions were really indisputable. And nothing very much happened most of the time. Like it'd just be, maybe there'd be some nice words said, or maybe there'd be some discussion, but policy didn't change, and places kept closing. So we decided a little while ago to make a film. And I'm going to start with a clip, a trailer for this film. It's called "Where Was I Born, Mama?" And I believe we'll be able to watch the film. Won't show? Okay, well, sound but no picture. And do we have a backup on that? That's fine. We don't need it. Let's just go back to slides. So we created a film, and you're all welcome to go and look at it online. Where Was I Born, Mama? And it's really the women of rural Ucluelet talking about their birthing experiences and actually presenting the very things we found in our research in a natural way. So I think it was a real, it wasn't hard to get those research findings out again, even though we spent a long time writing them up. So we have no conflict of interest related to this presentation, aside from a burning idealism about improving rural maternity services, which just doesn't go away. The rural Canadian landscape, not only for maternity services, but for a number of other health services, has really been a bit of a wasteland over the past 20 years. There have been continual closures, loss of services. Maternity is only one example of that. You'll see here that it seems like it's coincident with regionalization. And regionalization was really a wise investment, a wise economic decision that was made across Canada and across Australia as well. in trying to increase the efficiency of rural health services. But what it resulted in, the unanticipated consequences, was that a loss of voice, a loss of agency for small communities that were suddenly being run from Kelowna in the interior or Prince George in the north. And a lot of services closed. And that's still happening. And one of the wise elders of the Society of Rural Physicians of Canada said, you know, it's not that anyone is actively dismantling rural healthcare, because that's what it seems like. It's actually that we're not working hard enough to support it. And what he was alluding to, without really potentially intentionally doing that, was we need more information, we need more research. It certainly is what spoke to us, because you know, the fact that Jude and I have the opportunity to come here and speak to you as experts in rural health services research is a reflection of the fact that we need you all to start to join us and to help us, because there's a lot of work to do. And so our excitement in this meeting is to actually see if we can inspire some of you to think about that. You may already be thinking about it. So the goal of the Center for Rural Health Research and the Rural Health Services Research Network: support safe and sustainable rural health services. You can read the rest of that. So we have a series of strategies that we've invoked, and we're going to spend most of our time talking about those strategies. I'm going to lay out a blueprint for the strategies. Jude's going to populate those strategies with some examples, and our coordinators, who are very much a part of our team, are going to actually go a little deeper into those strategies. So I hope you'll really see how we are thinking about improving rural health services, primarily in the area of maternity, but it's to do with a lot of other aspects of rural health services like transport. So the first one is systematic literature reviews, because I think that that's really where you need to start, obviously, and you're all familiar with how to do that. And one of the ones that we focused on is rural patient transfer, and Jude's done a report on that, and we'll be talking about that in the RER section of our workshops. We're talking about the process of that. In wanting to influence you a little bit to consider doing some work in rural health services, as we're sitting here, as I'm speaking, or as Jude's speaking, if there are questions of clarification that come up, we'd like to have that dialogue. So if you want to put your hand up at any point and ask about something I'm speaking about, in terms of clarification, I'd like to entertain that. We'll provide time for questions at the end, for sure. So the problem is that high acuity transport in BC is a tough situation. It's a very mountainous terrain. You have to be cognizant of the weather. You know, when I was looking after a woman in early labor on Haida Gwaii, way back at the beginning of my career, I'd look at what time is it going to get dark, and what's the weather like. And I would make my plans for how to manage that pregnancy and whether I was going to deliver her locally, because we had no cesarean section capability there. So we were either going to deliver vaginally or we were going to transfer. And transfer was going to be 4 to 6 hours if everything was good. So a challenging situation to be in, and one that, especially in British Columbia, and that's true for most places. The second strategy is one that looks at population catchments, and this is something that we've published about, that we've used in research looking at outcomes in rural maternity care, and it fundamentally addresses the issue of population outcomes by not what you're doing, but how the population that you're responsible for is doing. So we create a population, a 1 hour catchment for each remote community in British Columbia, each rural community, and we go up to about 25,000 people, and we look at the outcomes, we create the map, we identify the postal codes that are subtended by that map, and then we look at the outcomes that are related to that. We look at, so we can say to Fort St. John or Fort Nelson, you know, this is how your maternity population is doing. And if there's an innovation in Fort Nelson or Fraser Lake, or you name it, we can actually talk to them about how their innovation is going. And we think this is something we should be applying to a whole range of health services. So we built these population catchments, and we're applying them to a range of services and invite projects that are interested in using the catchments to join us. So this is a map of the health areas, local health areas in British Columbia, and it's how most of the outcomes are reported. If you look at this a little more closely, and let's just take one of those local health areas, this is number 57, Prince George, you can see right away that the local health area includes not only Prince George, but McBride and Mackenzie. So if you're trying to plan services in McBride or Mackenzie, and you're obscured by the population of Prince George, you're not going to see very much. Maybe a little easier for Prince George with their larger population. So what we've done is create 1-hour catchments for each of those communities. And this is what a service level color-coded map of British Columbia looks like, just conceptually. So that's one piece of the work that we're doing. Another strategy is strategic partnerships. You know, so we believe in partnership with rural communities. And historically, when regionalization was invoked, one of the losses to the system was hospital boards. And you know, the hospital board was completely, admittedly, an inefficient structure. It was a group of local people trying to manage their hospital services in a reasonable way, grounded in the expertise they had in their community, but lacking any expertise of an overview of the whole province. So we're not suggesting that hospital boards be brought back. It's not going to happen. But what might happen is we need to think of some way of getting that voice back to the table, because we've lost a lot of expertise in that. And it's coincident with a significant erosion of those services. So some potential solutions that we've considered are maybe if we can combine the data that we generate from the catchment mapping that we're doing and allow the local data board or local committee to be involved in planning services supported by an evidence foundation of what's reasonable for them to have, that might be a good way to go. So that's something that we have talked about. The BC Rural Health Network is an example of a grassroots initiative that's arisen in response to the lack of that community voice. And this is led by a group out of Princeton, and includes now 13 communities, and is becoming a stronger and stronger advocacy group for rural communities. And the last strategy is knowledge translation. And the film I tried to start this presentation with, which I really wanted to test before we started, by the way, is an example of innovative knowledge translation strategy. And I want to close my first half of the keynote by trying another video. So I'm just going to put my fingers together on this one. These are some examples of other initiatives that have been launched recently to try and move forward rural health, improve rural health, improve rural health education. And I want to introduce you to Elizabeth Moore. She is the mayor of, she was the mayor of the Massive Band. And if I click on any, oh, that's good.
We've given birth for hundreds of years on high-fly without anybody, like without any special doctors and equipment. And then as the medical system developed more and more, there became more restrictions on who, what, where, when, and how, and why you can give birth. So we got to come to a medium. We got to come to a place where we can understand each other and use each other to create a safe place for beautiful children to be born. So.
When Elizabeth did this clip, she said, "This is a message to policymakers and planners. I want people out there to know how we feel and what we want them to do." And Massive has had no services, no local maternity services since around the time this clip was made. So we haven't yet responded to her challenge. I'm going to pass the baton to Jude.
Thank you. So I'm absolutely delighted to be talking about rural maternity care, and I'm going to actually talk about a few things and very clearly look at the rural maternity care situation through my lens. It's my story about how I've interacted with rural maternity care, and my story starts a little bit earlier actually than Elizabeth and some of the work we did. And it starts with a very idealistic move to Salt Spring Island after graduate school, where I moved actually with two small children. I wanted to bring them up in a cabin in the woods somewhere. When we got to Salt Spring in 1998, we had just gone through the legalization of midwifery in BC and public funding of midwifery. When I arrived on Salt Spring, actually thinking that at some point I would like to extend our family, there was no maternity services. They had a moratorium on maternity services because physicians had chosen not to practice anymore with the advent of midwives, but the health authority wondered if it was safe for a midwifery-only practice with no physician backup. So when I arrived, my question was, oh heavens, what are people doing in all the other communities where this is happening? What happens when women are forced to leave their community and go somewhere else to give birth? And I hadn't even considered it, of course, coming from Vancouver. A little bit of background when I arrived. This picture is really dated. On the left-hand side is Maggie Ramsey. And so she's the midwife on Salt Spring. That picture is stunning because it's 1979. It was at her first birth, first baby she caught. The woman birthing is Sally Sunshine, giving birth in a field, as many people did on Salt Spring Island. And Maggie said she's very appropriately just sitting back, letting it happen in case she needs, being there in case she needs some help. So that's kind of the historical context of birth on Salt Spring Island. So, with the concern when I arrived 20 so years later that there might not be a strong presence of maternity services on the island, I started asking questions and looking at the literature. What were the experiences of women who had to leave their community to give birth? And we found very little. There was some from the very far north, some excellent writing from about the evacuation policies of our colleagues in the very far, or women in the very far north of Canada, but not much else. So I was curious to see what we could find. Stefan and I started a program of research with two studies, one from CIHR on simply rural women's experiences of maternity care. As a young rural woman, I had no idea what that would be like, and I wanted to ask people. And we were supported by the Status of Women Canada. And this was about in 2003, where we were looking at what it would be like. So qualitative research. We came out with quite a strong understanding of the devastation of having to leave one's community to give birth and the stress incurred for women in leaving one's community to give birth. Right away, we started with a knowledge translation plan because we saw this as being completely untenable. So we worked early on with the Ministry of Health, health authorities, Society of Obstetricians and Gynecologists of Canada, Society of Rural Physicians of Canada, to wave the flag and say, this is a problem. This is an inequity, and we suspect it's leading to not very good outcomes. Right away, the questions we got from the key decision makers, and this was actually someone who I'll leave nameless but was an Associate Deputy Minister of Health, said, well, how stressful is it? You talk about stress, but how much? And did this have an impact on outcomes? So we went, okay, we don't know. So what we thought was going to be two discrete studies actually turned out to be the seedlings of our program of research. So the next thing we did was developed a scale to measure prurient women's stress in rural communities. And we validated the scale. And we found, in fact, that rural women who did not know where they were going to deliver, which is what happens when you don't have local services, or when you have local services without access to cesarean section, because about 40% of the women are transferred out, a lot of stresses occurred. As a matter of fact, their responses were 7 times higher in terms of their perceived stress than other women. And then we looked at an epidemiological study on maternal newborn outcomes, both based on 2 things, based on level of care in the community, but also when there's no care in the community, how far you had to travel. To us, this was kind of a duh study, like the further you go, the worse your outcomes are gonna be. But we had to show it. And in fact, although we absolutely approached it with equipoise, that's in fact what the data showed, and it showed it significantly, to the point where if you were more than 4 hours from a maternity service, which a strata of our population are, your chances of perinatal mortality were more than 3 times higher. So we published on that, the Distance Matters study. We looked at midwifery specifically in terms of the outcomes, and then Stefan led the study. That was a Canada-wide study. So the Distance Matters was local to British Columbia, 50,000 cases. Of course, you always want to replicate the study and have more cases. So we looked at BC, Alberta, and Nova Scotia and did the cohort study, which pretty much found the same things. So it was becoming very clear that we needed local access to maternity services in these small communities. But where? So this is Clem 2 on BC's Central Coast. Does anybody know where Clem 2 is, or has anyone ever been there? No. It's a very tiny community, I'm not surprised. So Bella Bella, you might know, on the Central Coast. Okay, so this is an hour by water travel time north of Bella Bella. And Clem 2 is a beautiful small community with about 500 people in it. Should Clem 2 have local maternity services? Yeah, probably not. So we have an intuitive understanding that Clem 2 probably shouldn't have services, but what about Merritt with 12,000 in their population? Probably, but there's a big gray area in between, and how do we decide? So we looked in the literature and looked at all of the influencing factors from a health services perspective and developed something called the Rural Birth Index. So the Rural Birth Index looks at population, so the number of births in the community, isolation, so distance to the nearest cesarean section service, and the vulnerability of the population, how easy it is for people to get out of the community and go to a regional referral center. We worked really closely with our colleagues in Australia. We go back and forth a lot, and the Australians, lovely for us, validated the RBI in Australia because the health service conditions are so similar. So they did the regional birthing index, the Australian regional birthing index in it. So that gives us a sense. So this again is something that healthcare policymakers can use when we're trying to not respond to the people who are yelling the loudest, because those are usually the communities that have the social assets to be able to advocate for themselves. What we want to be mindful of is the communities that actually, and I work in many of them, are worried about food, clothing, and shelter. Those are the ones that we need to be mindful of. So we always want to make sure, and Stefan alluded to this already, that we put things in context. So we did a systematic review, a realist review about the safety of maternity services without local access to cesarean section. You're all familiar with the quadruple aim in British Columbia. Of course, we want to make sure that patient outcomes, patient safety is very well respected. So we're doing pretty good. This is about 2000, well, this came later, but the research was really being clear at about 2009, 2010. So did that stem quell the tide of the loss of services? Yeah, no, it didn't. So these are the services that have closed, the maternity services that have closed in the past 15, 20 years. And I didn't have Fort Nelson at the upper top. And I'll end with actually a closure that happened 2 days ago. Well, I happen to be at Quality Forum, which is fairly devastating. I'll talk about that in a minute. So services continue to close. So maybe the issue is that there's no policy context for this. We need a policy context to enact health system change. Yeah, except for there is. And it actually starts with the Canada Health Act, where we facilitate reasonable access to health services. Reasonable access to health services based on population need. So we start with that. There's, in British Columbia, the Royal Commission on Healthcare and Costs was commonly called Closer to Home. And it was all about making sure people had care reasonably, safely in their home community. And it was the mandate in 1993 of health services planning. Since then, I won't go through them all, but the standards of accessibility also. And the standards of accessibility actually recognize something that Stefan was talking about, that there could be a negative impact on regionalization, and we have to be careful. We have to be very mindful that we mitigate that. So we have, in BC, policy documents. We have the professional associations, the provider associations issuing statements as well. One of them being SOGC. And they strongly promote returning birth to Aboriginal communities. We also have SOGC's more general, sorry, I don't have the title here, it's called Rural Maternity Care, Policy Statement on Rural Maternity Care. Same thing. Women should be able to give birth as close to home as possible. But it wasn't happening. So at this point, what have we learned? Well, first of all, we know that it's safe to have small volume rural maternity services, but we also know that culture eats strategy for breakfast is a quote that we often hear. And what I mean by that is we have a strategic approach that's informed by evidence and policy. Why isn't it happening? Well, it's not happening because we have to attend to the larger cultural influences. And those include risk aversion, a rising cesarean section rate, and an ethos of specialist care, the importance of specialist care. And I'm not for 1 second saying that specialist care isn't important. But in maternity care, we can look at the percentage of women that go to have regular, normal vaginal deliveries. And we can be grounded in what we know about the epidemiological data about who's likely to go on to have a normal vaginal delivery and who might need a higher level of care and triage appropriately. But we don't do that right now. So sustainability of these services, the few that are remaining, is super important. But how do we do it? Well, one thing we recognized is that it's very, very difficult to support a maternity service when there's no access to cesarean section, not because it's not safe, because we have both primary data and secondary data that it is, with certain caveats, but that it's hard on the providers. It's very difficult to have no safety net and to run into trouble, as you might do in a moment's notice, like Stefan had many times on Haida Gwaii and all the providers will talk about, and know that there's not an obstetrician down the hall and you're it. That is a daunting thought, so it's very difficult to sustain providers in this model. So there, we started looking at the importance of cesarean section and how we could promote cesarean section in a small community that's not going to have enough volume for a specialist obstetrician. So the model in Western Canada is one of GPs with enhanced surgical skills. So what do we know about GPs with enhanced surgical skills? I haven't included them, but we've done, Stefan's led a study on the outcomes of GPs that do cesarean section to add to all the growing international literature. We know they're safe. We know that this is a very efficacious model to use, but how do we implement it? So we looked at, we've in the past couple of years been looking at how we implement a surgical network, and we've been funded to implement a surgical network in British Columbia to support the vulnerable cesarean section services. Back to feeding culture, I'm just going to end on these last 2 slides. Feeding culture is about having integrated discussions, knowledge translation discussions with all the key stakeholders. And in a learning health systems and in an iterative approach, I'll tell you one thing I've learned without fail, that whoever you don't have at a table when you're making these kind of decisions or having these kind of discussions are the ones that are going to come back to haunt you. They're the ones that are going to create the most problems. So we need to have everybody, the pentagram partners, so that's healthcare decision makers, it's healthcare administrators, researchers who have got the evidence, local providers and communities, community members, all sitting at the table. So we did this in 2 phases. Last June, we had a symposium where we had all the providers and administrators come down to Vancouver and talk about what their issues were. And then we had a follow-up symposium in October where we gathered everybody from the Ministry of Health and the health authorities to listen to what the problems are, to start brainstorming a solution. The solutions that we did were presented to the Joint Standing Committee on Rural Issues for funding, and it looks like we're going to get funding to implement those solutions. So it's taking the evidence and research that has been growing into logical policy conclusions. And it's really important to remember your audience and who you're targeting this at. Academic papers are awesome and important, and I wouldn't for 1 second tell a group of MPH students not to write academic papers, but that's just part of your knowledge translation efforts. So at the center, we think of a tripartite strategy. We do the academic papers, peer review is important, we do a policy brief, and we do a report to the community. So those 3 approaches have worked really well. Second last slide is, I don't know if any of you were at Quality Forum, but at Quality Forum the last few days, we had all the healthcare decision makers and strategists from across the province gathered, really great discussions, and lo and behold, we all started getting texts 2 days ago that Williams Lake, which is a regional referral center, was on diversion for maternity care. They were closing their maternity services. So Williams Lake is a population of about 20,000. Their greater catchment is about 20,000 people. Not only that, 100 Mile House is a small community that flows into Williams Lake. Lillooet is a small community that flows into Williams Lake. And Ballacoola, where the New Hope people live, is an indigenous community that flows into Williams Lake. They all have, that whole region, as of yesterday, no local access to maternity services. So this is a real and persistent problem. The optimistic side of me says sometimes things like this actually drive policy change, so you better believe there's been a series of emergency meetings saying what are we going to do, because we are going to see the effects of this health service decision and the health outcomes very, very quickly. I'm going to end by cycling back to the midwife I introduced you to, sitting in the field, helping Sally Sunshine. This is her holding my daughter, who was about 4 hours old. 22 years later, she retired 2 years ago after what she says was 27 years of being on call constantly. And she's happily tending to her garden on Salt Spring, and there is still thriving maternity services on the island. Great, thank you.
We do have just a few minutes actually now to take some questions from the audience for Dr. Grabowski and Dr. Cornelison. If there are some members of the audience who would like to share some of their questions. Yes, okay. So what we're going to encourage everyone to do is that we do have a live stream going on. So if you have a question, if you don't mind just standing up, sharing your question, and I would just ask either Dr. Grabowski or Dr. Cornelison to repeat the question into the mic to our camera, and then be able to respond that way. I really appreciate that. So I think we have one question from the audience over there.
Hi, my name's Alyssa. I just had a question about out-of-pocket expenses for women traveling within rural areas. Have you been looking into that lately?
That is such a good question. So she just asked about out-of-pocket expenses, because in a lot of the economics data that we found, of course, that wasn't included. And that's a huge expense to women who leave their community. We did a study in Bella Bella, just one study where we got all the financial records, and it cost, the average cost for women to leave the community to go and give birth was $3,200, 32 something, $3,200. So what we're doing now is a province-wide survey that's being led by Dr. Khawaja, Asif Khawaja, who's a postdoctoral healthcare economist. And we're through our networks, administering a survey to ask exactly that, so we can get data from around the province that will tell us what those out-of-pocket expenses are. We know from the narratives that they are significant. We know that it's accommodation, it's housing, accommodation, and transport, and also the associated costs of lost wages and leaving the community, and things that add on to that, like if they need someone to look after the house or property or pets, or whatever. So we know that it is substantial, and we're going to have that data really soon. Good question.
Hi, my name is Claire. I'm just wondering if that $3,200, does that include the partner or, say, a family member coming with them as well?
Even better, well, very good question. No, it doesn't. And luckily, if you were following 2 years ago, Jane Philpott, when she was still Minister of Health, announced funding for escorts for people, for Indigenous women leaving their communities. Because up until then, women would say to me, we can't afford to bring my partner, or more likely my mother. And it's very important that, women have their mothers with them, or aunties. And the sadness was very clear about not having anyone come down with them. And I'll just tell you one quick thing. I was in Bella Bella once, and there was a bingo thing happening at the hall, and I said, oh great, what are you, it was a fundraiser. And I said, what are you fundraising for? And I learned that a mom was fundraising to go and have her baby. And this is in our healthcare system.
Hi, Richard Lester. I'm a physician in infectious disease at UBC, but I grew up in Smithers, so in the north. Nice to hear about the Haida Gwaii scenario. I just kind of want to point out too, so one of the things for innovation for practice, for instance in Haida Gwaii, and we'll be doing a workshop on this afternoon for those who are interested to attend, and Alyssa actually has a poster. So the family practice unit up there has adopted a text messaging program for patients, and
Well tell.
Yeah. So that'll be happening a bit later, but just in terms of your experience for getting programs that are locally driven to scale into the provincial things. Do you have any comments on examples of how those, what you might have seen work?
Okay. So the issue of spread and scale is fundamental, especially in rural communities where there's a high degree of a natural geographic isolation. So what we found when we did the 1A site studies where we brought everybody together, we got funding for that, and we did that because everybody was saying, what's Salt Spring doing? What's Hazelton doing? We don't know, we're isolated. So we see the beginning, and fingers crossed through the Academic Health Sciences Network that they're gonna also take on some of that coordination role of spreading where the innovation is happening. There's an organization called the Rural Coordination Center of BC right now, and specifically with rural I'm speaking, they're going to all of the rural communities in BC, or trying to go to all of them, to learn about what innovative practices are happening, and then be able to scale them up at a provincial level. So I think it's early days, but the system itself is recognizing the importance of doing that, so we're not reinventing the wheel in different parts of the province. Yeah.
You know, I think that our third strategy was around community engagement. And you know, if you had members of the community sitting around a table going, we've got a problem here, and oh, look what they're doing over there, we need to invoke this in our community. I think that's the kind of dynamic that can actually lead to change. And if you're trying to do it from the top down, you know, it's scaling up is a perennial problem for us across our healthcare system. Go ahead.
Hi, my name is Netta, and I'm a registered nurse, and I practice in remote communities of 200 to 400 people. And in these communities, often there was just 2 nurses, and the nearest hospital was anywhere from 3 to 4 or 5 hours away, either by land or by air transport. And as you guys know, they tend to not come after hours. And I'll never forget the anxiety going to sleep on call with pregnant women in community that were close to their 30-week mark that would typically be shipped out around the 30-week mark. And I was just wondering if there's any nursing voices in communities like this where there are no physicians, it's just 2 nurses, and if there's any training or follow-up, like anything that can be implemented in communities like that. Because I remember being, put in communities and having absolutely no training in maternity, and just that anxiety. So I'm just wondering if anything can come in for nurses.
Yeah, that's a very, very excellent question about the training for nurses. Just to repeat, and the anxiety that nurses experience. And Kira's going to be talking a little bit more about that, Kira and I, in the workshop, but just really briefly, our work in the North Island, the Kwakwaka'wakw territory, the North Vancouver Island, involved focus groups with nurses because the number one, I didn't know if you noticed in the article about Williams Lake, they are on diversion right now because of lack of nursing. That is the reason, not primary provider, or MRP, it's the lack of nursing. So when we asked the question in the North Island, how comfortable are you with, assisting with normal vaginal delivery? The nurses were saying things like, way rather do an acute MI than a normal vaginal delivery, right? So that's daunting. We also asked, we had a focus group of 8 nurses, and we said, okay, how many normal vaginal deliveries have you seen before coming here? And there was a pause. 6 of the 8 had never seen a delivery, and they were put in a remote, difficult, socially complex patient environment. They had never seen one. Of course, they'd rather do an acute MI. They have training in that. So nursing is super important part. The application that's just gone into the JSC for funding has a huge portion to support nursing education and training, have them rotate through high volume sites, do on-the-ground simulation and interprofessional simulation around birth. It's key.
I'm going to add that too. Just one, and then I'm going to come to you. I'm sorry about that. But, if there was just a master's student around who knew what the question was, so we could drive the right research. That's what nursing pressure. Please.
Just not knowing the BC environment as much. I did work in northern Manitoba, but jurisdictionally with First Nations Inuit Health Branch, and then there's the First Nations Health Authority. I'm just curious about how you see planning services in a multi-jurisdictional environment and who should be leading it. And you mentioned some stuff about local health boards, and I was thinking about First Nation representation with those, and if it's going to be, just your thoughts on that.
Yeah.
I'm going to make a short comment and then pass the mic to Jude. But, and this is our last question. You know, fundamentally the answer is collaborative. You know, and there was a partnership meeting with First Nations 2 weeks ago in Vancouver to talk about unrolling the primary care network and unrolling patient homes, and it was phenomenally successful. And you know, there was a real opportunity to move ahead together. So again, we need some leadership to get this ball rolling. And I think that I can see one person. Great.
So I don't know if your experience was in a First Nations community?
Yeah.
Yeah, so we're working closely, we're developing our relationship and our collaboration with FNHA because they're very aware of this. So what I think is needed right now is a just-in-time nursing curriculum with First Nations Health Authority for the very small communities that are now, it's not going to be feasible ever to have local deliveries, but you are going to have to look after the occasional pregnant mom. For across the board, your question of integration between, because it has to happen, between FNHA and the regional health authorities is an important one. FNHA doesn't provide, aside from the nursing care, doesn't provide clinical care, right? They provide community care, but there are areas where with a bit more coordination there can be really productive synergy, and I think those discussions, as Stefan alluded to, there was a big meeting 2 weeks ago, I think those discussions are starting to happen because of the on-the-ground pressure to solve some of these issues. Good question.
So we have the privilege on our team of having 4 recovering master's students to lead the next section of our program, and we should get them up here and have them talk to you because they're well, they stand in almost your shoes. So
yeah.
Thank you very
much. So come on up, Kira and Christine. So in the center, we have program streams of research that we focus on, funded research we focus on. So we have something called the Rural Evidence Review that Christine's going to talk about, and she runs the Rural Evidence Review stream. We have the BC Rural Health Services Research Network that Yvonne runs as a coordinator. We have the Rural Surgical Obstetrical Networks that Unsu run, and we have the Building Blocks Project, all the 1A work that Kira runs has been running. And you know, we just recognize that probably hearing directly from them would be most interesting to you instead of hearing from us, and we are very delighted to introduce, starting with Kira.
Great, thank you. Hi everyone. I'll just start, I think some slides are coming, but I just kind of want to tell you a little bit about my story and how I got here and what I do at the Center for Health Research. So my name is Kira, and I have a Master's of Science in Global Health. I've been out of my Master's just under 3 years now. Kind of what underlies what I do and why I'm here is kind of a desire to use research to work towards addressing health inequities. So this kind of started for me in an internship I did in Indonesia, working with the WHO Stop TB program. And I was so fascinated by the idea of a disease that we have a cure for it, essentially. We have pills that you can take and kills the bacteria. However, it's so much more complex than that, and so I was really fascinated by all the social determinants of health I saw working in remote Indonesia. So access to clean housing or water or food and all the barriers around transport. So I was really fascinated by that, and that led me to go and get some more education to kind of understand some more of these challenges. And so I completed my Master's in Global Health at the University of Dublin in Trinity College. And I had focused there on maternal nutrition. And from there, I went and did some work with a research organization in Phnom Penh, Cambodia. And so there I continued to look at maternal nutrition, and so I did some research there. And upon completing that, I was really curious to see how my global experience and education could be applied to my own country, to Canada. And that's where I came across the Center for Rural Health Research and saw the work that June and Stefan were a part of, and really found my values and my skills could really maybe be applicable here in rural Canada. So I was excited to do that. So that was just a bit of my journey. There it is. So the project I work on now at the Center for Rural Health Research is the Building Blocks to Sustainable Rural Maternity Care, so the North Island Project. And that's a 2-year project that we're near the end of now.
And it's a really exciting project. What it is it's basically addressing a gap that exists. So as Jude mentioned, we have really strong policy context and evidence. We've talked to many rural women. We understand the importance of local care. But we have a gap in actually the system supports to actualize this care. So how do we actually support providers to provide sustainable rural maternity care? And we were looking at the North Island for this project. So that's what we were looking at. So it started with going to communities, talking to moms to understand, yes, there's a strong desire for local care. And then talking to the providers, so the nurses, the doctors, the administrators, to understand, okay, what do you need to be supported here? And so that came, that actualized 5 building blocks, what we call building blocks to sustainable care. And we'll go into more detail on some of this in our workshop, but I'll just briefly go over them. So the 5 things that arose here, and it was, Jude reminded me, is kind of interesting how it came about. Jude was in the North Island near the beginning of the project and was sitting down with one of the local physicians, and essentially she's like, what do you need? Like, what do we need to do here? And he essentially was like, we need local transport, we need access to reliable local transport, we need stronger interprofessional teams, we need to look at who's staying and who's going, like what's an appropriate level of risk. We need nursing confidence. Nursing was such a huge one. It was first and foremost for most people. And so looking at all those things, and we need to be supported by our regional referral centers and have stronger networks of support. And so that's kind of how it came about, and as the project progressed, as you mentioned, we took what we heard to the other low resource communities in BC, the other 4, and that really resonated with them as well. And so then that was taken further to policy and decision makers, and has kind of now come about in this proposal to hopefully actualize some of these recommendations and evaluate them and sustain these low resource services. So that's just the really brief. There's so much more I could talk about, and Jude and I both love talking about it, so we hope that you have questions for us. We have a couple posters that we're presenting out there after, so come and look at those and join our workshop. Yeah, happy to chat more.
Hi, my name is Lansu, and I'm the coordinator of the arson evaluation at CRHR. I completed my MPH with a specialization in global health in 2010 from Simon Fraser University. So I'll start off with my values. Probably like most of you, since a young age, I've been aware of disparities around me and in the world and wanted to do something about it. Growing up, this was especially true when I would visit Nepal, which is where I'm originally from. For instance, one summer I volunteered as a substitute teacher at a public school in the town where I was born. And you can see here pictures of the students at the school. And during my time volunteering as a teacher, I saw how limited access to resources and opportunities impacted my students, and I'll share a story with you to illustrate that. So one day, at the end of the school day, all of the grade 3 students had left for the day. That is except for a group of girls that were standing gathered around a desk. I went to see what was going on. They were gathered around a student who was sitting at her desk sobbing, and she was sobbing because someone in the class had stolen her only pencil, and she was afraid that her guardians would get really mad at her. I took her across to a shop across the street and bought a new pencil for her. The pencil cost only 2 or 3 Nepali rupees, which is equivalent to about less than 5 Canadian cents. And so before this, I would have never imagined that losing a single pencil could be such a crisis for a young student. So fast forwarding to my MPH. Like I said earlier, I specialized in global health, and for my practicum, I worked with the sex worker collective in South India. I conducted a situational analysis of female sex work in a district where the collective was less successful. On the left is a picture of me and my classmate having lunch at a restaurant run by sex workers. This restaurant, which served delicious food, was located directly below the sex worker collective office, and we would regularly have lunch there. The second picture is of me and one of the staff members at the collective. She also served as my translator during data collection. So I completed my MPH in 2010, and since then I've been working and volunteering with different organizations, evaluating various health-related initiatives and programs. So currently I am working on the RSON evaluation, and RSON stands for Rural Surgical and Obstetrical Networks. It's a program that's being implemented in 8 rural communities across BC. RSON started with the desire to sustain maternity services in rural communities. For maternity services to be more sustainable, you need local access to cesarean section. And for cesarean section to be more sustainable, the cesarean section has to be part of a broader suite of surgical and obstetrical services. So RSON aims to support and sustain local surgery, operative delivery, and maternity care. And the RSON program supports this through 5 different ways. So they're called pillars, so 5 overlapping pillars, and they're listed on the screen. The 5th one, evaluation, is what CRHR is leading. So we are currently in the process of planning and implementing a comprehensive evaluation of RSON. The evaluation is innovative in its approach. For instance, we're not only looking at surgical outcomes at a facility level, but also at a population level. So that is surgical outcomes for all residents living in a geographical network catchment, regardless of where they receive care. We are also looking at costs. So not just the cost of providing surgical services, but also the cost of not providing these services, including the cost to patients when they have to travel outside of their community for care. And so you'll see the 4 evaluation streams in the blue text boxes, and they're all being developed using a shared measures framework with all key stakeholders. We hope that the evaluation will inform the iterative development and improvement of RSON, and also be useful to other Canadian jurisdictions interested in implementing a similar model of care. So if you have any questions about RSON or the RSON evaluation, feel free to connect with me or Jude later on. Thank you.
Hi everyone, my name is Yvonne, and I'm the coordinator for the Rural Health Services Research Network of BC. I completed my Bachelor of Science degree here in Global Health and Nutrition. And before I get started, I wanted to give you a little bit of a family background as to my story and how that shaped my values and my path. So my mom came from the northern region in Philippines in a small village called Tubu Abra. And my dad, he was also in one of the small towns in Vietnam called Binh Tre, and it's entangled in one of the largest river networks in the country. And growing up, they shared a lot of their experiences living in rural and some of the obstacles they faced with food insecurity, access to health services, educational and economical opportunities. So growing up, my brother and I were not unfamiliar of those challenges, and they worked really hard to get us to where we want to be and to give us opportunities that they didn't have growing up. So they played a crucial role in shaping our values and pursuing my path for addressing food insecurity and health inequity. So during my undergraduate, I was involved in various global health opportunities. I was involved in community development work in Ho Chi Minh, Vietnam, in a small NGO. To the left, I tried a little bit of some traditional music in Vietnam, but I realized I'm not cut out to be a musician. And in Bogor, Indonesia, I did a small monitoring and evaluation project. And what we looked at was the technological adoption of a rice strain for smallholder rice farmers. And we wanted to see whether or not it could improve agricultural productivity in that area. Fast forward, my main interest within global health, what I've experienced throughout my time was, it was intersected with visual and health communications, in addition to digital media. And what I found in academic institution was a need to develop media and communications literacy. So there's a little bit of a gap in strengthening knowledge translations in this area. And that is what drew me to working as a media assistant at the Center for Rural Health Research, where I was involved in communicating research findings through producing various multimedia outputs. And through that interest and passion, that led me to work as a network coordinator here. And what I will tell you about the network is we are serving to build research capacity in rural health services research. And what we are striving for is, what we work towards is helping rural physicians and students get started if they are interested in building their research skills. And we work to enhance collaboration, communication, and capacity. And some examples of that in the network include, for collaboration, we hold annual advisory committee member meetings. And this exists in various sites across BC. And the representatives, they hold a strong research background and interest in rural health. And they help inform the direction of the network. Another example is producing knowledge translation materials. And we circulate newsletters with relevant resources linked to rural health services research. So this can include some funding opportunities for students, some continuous professional development events, and some conferences perhaps. Another is we also build infographics with the Rural Coordination Center of BC in their northern node. So we're working towards developing toolkits for these rural physicians if they can't receive the one-on-one help right away. And lastly, we also hold funding opportunities. So if any of you guys are interested in pursuing rural health projects, we have various funding for that. Some examples include funding for FLEX programs, and we also have FLEX team building awards, so this supports multidisciplinary research teams, or even travel bursaries for researchers who are presenting their work in rural health nationally and internationally. So these are some examples of the activities that the network does in supporting capacity building. And if you guys have any more questions or want to talk about some of my experiences and how I got to working here, please feel free to connect with me after. Thank you.
Hi everyone. Hi everyone, my name is Christine, and similar to two of my colleagues and to, I'm sure, many of you in the audience, I come from a recent background in public health. I graduated about a year and a half ago now. I studied at the University of Toronto, where I specialized in health promotion, and currently I'm working as a research coordinator with the Center for Rural Health Research. So I'll give you a quick snapshot of my background. My path has been meandering. I completed my undergraduate studies here at UBC, where I studied nutritional sciences. And it was during those studies that I developed an interest in community nutrition. So this led me to pursue two different opportunities to work in community development in Kenya. While in Kenya, I just loved the opportunity to work so closely with these communities and work with community-based organizations, and it became very clear to me that I wanted to pursue a career where I could address the social determinants of health. And that led me to my Master of Public Health program at the University of Toronto. And then after graduating at U of T, I have found myself here working with the CRHR as the coordinator of the Rural Evidence Review project. Oh, and yes, so despite the fact that my path has been somewhat winding, there have been several core principles that have really underpinned my trajectory, and I have found that throughout my experiences, these principles or these commitments have been reinforced, and these are commitments to health equity, social justice, and evidence-informed decision-making. And so it's no wonder that I've ended up at CRHR working on the Rural Evidence Review Project. And the Rural Evidence Review Project, we aim in the Rural Evidence Review Project, we aim to work together with rural communities across British Columbia to produce or to provide high quality and useful evidence for rural healthcare planning in the province. And so what that looks like in practice, we have a three-pronged approach. Although these are, I tend to describe these steps as 1, 2, 3, but of course it doesn't happen that way in practice, and it's a very iterative process. But the first being community outreach. So we ask rural citizens what their priorities for healthcare are. We then take those priorities and we do literature reviews on the topic to generate an evidence base. And then we try to promote the uptake and use of the evidence in policy and planning discussions in the province. And I can go on for hours about the RER, but I won't. I'll leave you with that. Of course, if you have any questions about it, please feel free to come up to me during these presentations. And also, Yvonne and I are going to be presenting in a workshop in half an hour or soon. So yeah, I'll leave us at that.
Questions and answers at this moment, and just like before, if we could have the members of the audience with questions to please stand up, clearly say your question, and then to have the panelists just repeat the question to the camera, and then whichever individuals feel prepared to answer the question, we would just ask you to do that as well. That'd be wonderful. Does anyone want to start off with the questions for any of our wonderful panelists?
Of course I will. So the theme of what we're talking about today is real world examples of the kind of work we do. And I think you'll find as soon as you're kind of immersed into the post-academic world that everything you learn is a wonderful starting place to launch from, but actually things don't happen quite that way. So in every project, we've had to adjust and adapt to changing circumstances, to political influences that we weren't anticipating, and to other challenges that we've encountered. And so I wonder if we can go through some of the unanticipated influences on the projects and how the coordinators have dealt with them. And maybe Kira, starting off with the Building Blocks project.
Yeah, for sure. There's quite a few I could talk about. It's really exciting to do research in the real world, I think. On the positive end, especially because, as I said in the Building Blocks project, it's been 2 years and there's been so much action because of the research, and so that's really exciting. But as Jude said, there's also challenges. One that I would talk about is, as we talked about briefly, one of the building blocks or key system supports is to have a really strong interprofessional maternity care team. And so in the North Island right now, there's no practicing midwife, there's no midwives there. And so that was one of the things that came out a lot from the women in the community. The desire for local midwifery care was really strong. And from the care providers as well, nurses wanted to work alongside midwives, and the physicians also recognized a need for that interprofessional collaboration. However, introducing a new provider group to an existing team has to be done with caution and in order to make sure that the service is not destabilized. So Jude and I had kind of undertaken this process of planning and really strong relationships, particularly with the physician team, where we were going back and forth, and we had this kind of planning process that at the end of this feasibility analysis to understand exactly like how could this model work, what would the team look like, what were people's roles, all that stuff, that we would kind of be able to like, okay, now let's start a hiring process and bring a midwife into the community. However, real life doesn't always work like that, and about a year into the project, a midwife moved up to the North Island, which was great, but not quite part of the plan. And so that was an interesting process because we kind of had this plan of how this would evolve, and that kind of threw it off a little bit and changed how we had to work. And so now conversations had to bring everybody in, and that kind of changed our process a bit. I don't know if you want to talk, you might have more to say about that, but
no, that's great.
Yeah, that was one of the surprises.
There's a question.
Oh, you can follow that one if you like. I was just going to say it was so nice to see many of your global health examples too, and I think it helps you realize the challenges in rural health are more similar across the world often than different. So in terms of being able to tie or share experiences from local rural health challenges and solutions to your global health experiences, how do you envision some of the best ways to do that? Big question.
Yeah, I love that question. I've thought about that a lot. I don't know if you guys are familiar with the Canadian Global Health Coalition of Global Health Research. So they've established 6 principles of global health research. And as I started my work here, I was just realizing these principles completely underscore the work and the process and the methods that Jude and Stefan use. And so one of the big ones for me that it's a global health research principle but applies here is cultural humility. And so I feel very fortunate to go into these communities and have the time to sit on the floor with moms and babes or in communities centers with elders and just gain their wisdom and just hear how they do it and what their perspectives are. And so I correlate that experience because I did that also in rural Cambodia, sitting on the floor of homes and hearing what their vision is. And so I think that cultural humility piece is really, for me, has been cross-global or global-local, whatever it's termed, yeah.
Just to also answer that a little bit further, there's a super, super strong relationship between GPs with enhanced surgical skills in low-volume maternity sites doing procedural care and the model in many international jurisdictions. And so we've made some really nice attachments with the global surgery program at VGH in their work, and you're exactly right, the parallels are astounding. We've just been having the discussions among the team, who you can see would be very, very curious and enthusiastic to work in a global health frame, to see how we can do reciprocal sharing of learnings from rural BC with other in areas of global health and also consequently learn from them. So good question.
Yeah, I have a question. It's interesting that the coordinators have backgrounds that are similar to most people in this room. And then the SPPH department has a lot of international students, most of whom are not even familiar with the rural health community in Canada. And most of us are hearing about TRHR for the first time. We're hearing about the Rural Health Services Research Network. So if people here wanted to get involved in rural health research or policy making or get involved in helping rural communities, what are the avenues? What avenues do you think we can explore?
Do you want to?
No, go ahead.
So just a few things. At a practical level, we have work-learn opportunities that come up every semester, and we have full-on positions in the summer at a practical level. And Zena, you're one of them, which is fantastic. But there's other opportunities. So we often do directed readings. I take a lot of, this wouldn't apply here, but a lot of flex students, so in the medical program, do projects around our rural health. And also, you know, in study environment, master students. One of our key priorities that we try to do wherever possible is to get definitely coordinators and research assistants and students out into the field. If you've had the opportunity to do field work in whatever area you're looking at, you'll know that everything becomes real when you're in a small community and it's pouring rain and you don't know if the plane's going to go out. All of a sudden things become very real in a way that you can't anticipate when you're just reading about it. So yeah, there's definitely opportunities depending on what a student is looking for. That's a good question, Zena, thank you. So please contact any of us.
I'm going to add a little bit to that unless one of you would like to. I think that you know, the failure I think that this has been is that we are having this meeting now instead of 10 years ago, because in fact the opportunities to work in rural British Columbia they're huge. There's all kinds of things that we should be addressing and doing, and you know, students like yourselves, if you're going to be effective in rural research, I think you've got to have the marriage of clinical expertise with research expertise. You've got to have those two things together, because the clinician understands the problems because they're living them, and the researcher understands how to actually study them. So I think that the way forward, Zena, in some ways is to actually pursue your interests. You know, when you voice an interest like you've you put forward there or there, you know, actually articulate the interest more clearly. And I always recommend a one-pager. You know, it's the beginning of everything in my research life. Write a one-pager, you know, like what's the problem, what are you trying to change, you know, and then contact, you know, one of these ladies, certainly the network, you know, Yvonne, or maybe someone who's interested in the content area that you're focusing on, and that's the way forward. And we will support you as much as we can, because we want people like you to be asking these kinds of questions. There's a dearth of understanding of rural Canada that needs to be addressed. Do anybody want to add to that? Go ahead.
Hi, I'm Elizabeth. I am a PhD student, but I'm also a midwife. I'm wondering, do you know, one of the challenges that I see for rural midwifery in particular is scope. And I know there's sort of interprofessional turf challenges because you get into crossover with the GPs who also are needed in small communities. So I'm curious what has been happening in BC to address, from my perspective, what needs to happen is midwifery needs to have expanded scope to include full scope women's health in order to sustain rural midwifery. But I can see the challenges that that creates, so I'm just curious what you can add to that.
You know, that's the kind of question where you just go.
Only because we have a little bit of a difference of opinion on that. So, just to put it in context, out of the 5 1A sites, 4 of them are midwifery-led. Haida Gwaii, Hazelton, Salt Spring Island, and Invermere. So midwives are sustaining the services. However, those sites are not sustainable because most of them have solo midwives. All of them have solo midwives. And you cannot run a service on a solo practitioner. So the question then is, what does interprofessional practice look like? Scope is one area, one approach to it, increased scope. I think before we get there, and there is increased scope for the Health Professions Act right now, right? So we're waiting to hear if the requested increased scope is going to come through, and we should hear about that in 2019. Before we even get there, we have to do 2 things. One of them is look at this through a rural lens. And I'll tell you that if you're a midwife in Vancouver at BC Women's and your colleague, a physician colleague, really ticks you off, you can walk down the hall and look the other way. If you're a midwife on Haida Gwaii, not a chance, because if you're sitting with a decompensating baby waiting for transport, you're going to want your colleague in there. Let alone in the clinical situation, you're going to be standing beside them on the soccer field where your kids are playing soccer. That's the reality in small communities. So interprofessional teams can mean anything from just being able to collegially say hello to fully integrated shared practice like in Nelson where the physicians are doing home births. Across the board. So we have to figure that out, and there's some huge obstacles, including funding models. Scope is part of it, but not the main part. There's culture and funding that we have to sort out. The other thing we have to be mindful of, the second thing, is the overarching health services frame. So I'll give you an example of Revelstoke, where there's great desire from the community to have midwifery services. Absolutely, they do about 100 deliveries a year. Revelstoke has also underscored their maternity service. If you've ever been there, it's pretty remote. Their maternity service is underscored by 3 GPs with enhanced surgical skills that do local cesarean section. The 3 GPs are in addition to 2 other GPs that do all the deliveries. If a midwife were to come into the community and let's say take 40 to 50 deliveries, it would cut the available volume to the place where the folks doing the cesarean section don't feel like they want to do it because they don't, they're family practitioners, they're not surgeons, they want to do full scope. And they have said unequivocally that they wouldn't want to continue practicing. So there we have the starting of the crumbling of services without cesarean section. I'm not saying that there's a right answer here, but what we do need is honest and authentic dialogue between all the professions at the table with a wide system view, as opposed to an entrenched view of the profession that can happen with any of the professions. We need to actually look at the health needs of the population. That's a very difficult question. There's no easy answers. And just to your point, there's a huge provincial meeting on March 8th to try and deal with exactly that. So good question.
I have just two parts to take on to that. Nowadays, education, interprofessional education is very much a core, at least at UBC, I don't know about other schools. So what are the ages of the average practitioner in rural communities? And is that affecting the attempt placement of interprofessional collaboration? And also, what specific professions are we talking about in interprofessional collaboration? Because in Vancouver, it would be a whole team of many different things. So in rural communities, are we just talking nurse, midwife, doctor? Are we just talking midwife, doctor? Like, what specifically are we speaking of?
And so, this really addresses a little bit of the last question as well. And fundamentally, the smaller the community is, the more generalist the scope of services that the providers have has to be. You can't survive as a specialist in a small community. There's just not enough of anything to do that. And so the movement of midwifery towards a broader scope of practice and becoming more generalist, of course, is, obviously that's the right thing to do. Or find another fit, because fundamentally, if you're just doing one thing and there's not enough, you can't do it. So I think that I think this is actually a great example of where we lack information and guidance from the research community. So policymakers are trying to invoke policies. The profession of midwifery is trying to populate the landscape and look after the women, and that's a good thing. And then they're coming up against structural barriers that make it impossible to survive. In a 1A site, really, you can't be by yourself and trying to do the whole load. It's really difficult. And the same thing is true for, for specialized nursing. So I don't know if I answered your question. Do you want to just reframe it if I missed it?
It was two parts, so maybe that's where it got a bit muddled. One was exactly what are the interprofessions that we were speaking of? Is it just midwifery and medicine? Is it midwifery, medicine, and nursing?
Yep.
And the other one is the age of the practitioners a factor due to how education has changed throughout the time?
Sure. So again, there's a systematic lack of planning of rural health services. Nobody has drawn up a template for how to do it. So what happens is a practitioner comes along, a nurse, a doctor, and the more general the better, likes the community and settles there, and they settle there for as long as it works out, and some of them age in a community where they fit well. And sometimes a community like Revelstoke has got a waiting list of people trying to get in because they have such a good model of practice. So there's variation across the board. And what we've tried to do is to develop templates of how to think about appropriately staffing a community, appropriate level of service, and appropriate staffing models. And they're desperately needed. So that's more work for you guys, actually, in the next few years. Go ahead.
And now I'll answer your question. So what we do know is that there is an aging demographic of specialists across the board, but particularly in rural communities. So they're in, I think it was the average age of a specialist in rural Canada is 56 or something. Likewise with GPs with enhanced surgical skills. I don't have the exact data because that's a kind of not antiquated at all. It's a current model, but the training happened in a big way, and the scoop from South Africa, quite frankly, until we put a moratorium on that, it was completely inappropriate. So a lot of our GPs with enhanced skills were trained in South Africa. So those two for sure are aging. From my observational experiences working in a heap a load of rural communities, there's also now a lot of young providers who want a different quality of life. The Vancouver housing market is pushing a lot of people out in a very practical way, and I see that in Revelstoke, where I was last week, in Golden and Fernie, like all of those places. So I think it's across the board, but I know for the specialists and the GPs with enhanced skills, they are aging, and that's a problem.
I have a question for you, and then we'll take your question. How many of you are healthcare providers, or have been healthcare providers, or still are? Quite a smattering, actually. Okay, great. What's your question? Go ahead.
Well, I was just going to say...
could you introduce yourself, maybe?
Yeah, my name is Aiden, and I'm a PhD student in SPPH. And I'm actually from Canada River over in David Island. And I think like their intervention there in increasing their health services is a really interesting model, and something we should look at it potentially. And from what I've seen, they have three things going on. One was the district decided that they wanted to invest in like a brand new state-of-the-art hospital. And the idea was that if they build a really nice hospital, then young medical providers and specialists would come and use it. And so far, that's turned out to be the case. And then the community supplemented that with like philanthropic or private donations. So they didn't have an MRI machine in the hospital, but members of the community got together, purchased the MRI machine, and again, then technicians and people were hired, specialists, in order to use the equipment properly. And the third intervention that I think is really interesting is that North Island College, 2 years ago, they started a nursing bridging program that allowed LPNs to transition to nurse practitioner or RN within like 2 years. And what's really interesting about that is that a lot of the students are from the rural community. So you don't need to look for people coming from outside. It's people that were born and raised there and people with lives there.
Thank you. We should probably wrap this up and have coffee. Do you guys have? Yes, there you go, Chrissy.
So just kind of to comment on what you said, and kind of to plug our work a little bit, but we just finished a review looking at community level strategies for recruiting and retaining healthcare providers. And several of the things that you've mentioned certainly came through in the literature, but it's just really interesting to read about what communities themselves are doing to try to recruit and retain, attract and keep providers. And so yeah, I just wanted to comment because that's something that there are many examples across BC, but also across Canada and in other parts of the world of communities that do things just like that. They fundraise or they implement a new municipal tax or whatever it is to build new facilities, to also build to develop the community, to build a YMCA, to upgrade the library, things like that, to just make it a more livable community. So yeah, thanks for sharing.
Any other comments from you guys? So thank you very much. That was
So I'd just like to thank the panelists and our keynote speakers again for sharing their wonderful ideas, and also to everyone in the audience for those really thoughtful and engaging questions. I think that's really in the spirit of SPPH Exchange, is to create this kind of dialogue, and I'm so glad that we've been able to do that here today. So I'm just here to talk a little bit about our next steps for the conference. So we will be hosting a coffee and refreshment breaks in case some people need some caffeine and are feeling a little hungry. We have plenty of food and coffee, and those will be in the lobby of the SPPH building. If you're not quite familiar with that, it would just be across the street at the main doors and a little bit up, and you'll see the SPPH building. We'll be in the lobby with plenty of food and drinks. Probably at 3:40, we will be beginning our 4 concurrent workshops. The titles and the room numbers of the workshops are available on the screen. We'll also have some signages in the SPPH building where all the workshops will be taking place. We do recommend everyone start kind of heading over there around 3:30 to make sure you can grab a spot in your preferred workshop. And the rest of the schedule for the rest of the conference is available on the schedule here as well, and would have been emailed to your registration email. I do know that there were still some questions lingering in the audience, so we thankfully have our panelists and our keynote speakers available during the coffee break and for the networking session this evening. So do stick around, and you'll be able to converse with some of our wonderful speakers one-on-one. So I, again, on behalf of the committee, would like to thank our sponsors, the Center for Rural Health Research and the Rural Health Services Research Network, as well as the Graduate Student Society, and of course to thank all of you for coming to this first half of the conference. And again, I encourage everyone to head over to the SPPH building and to see you around in the afternoon. Thank you.